Good morning, everybody. Just gonna give people one more minute here. Make sure everyone gets through the waiting room and we'll get going. All right, we'll go ahead and get started. Looks like we've got everybody here. Welcome to our fourth in this current series of echo sessions on treating patients with buprenorphine. This is our fourth and final series, but we will be back again soon, and I'll talk a bit about that once I get through my housekeeping stuff here. Again, the usual disclosure of relationships. No one has any financial relationships to disclose. Grant funding acknowledgement. Thanks to our partners at Nebraska DHHS for subgranting the state opioid response grant funds over to us to make this happen. And again, the usual process with STEAM research certificate. I'm going to get that email out to everyone later this afternoon. I'm not going to be able to get it out this morning, but keep an eye out for that this afternoon. Get a link to a survey and then just complete that survey to get your certificate. And I wanted to put a plug in for our next Echo series. So we'll be off in September, and then we'll be back in October with another 4 series cycle of Echo sessions. These are going to focus on co-occurring mental health and substance use disorder diagnoses. So we've got Todd doing one on treating patients with mood and anxiety. We've got Ed coming in with a sort of a refresher course on buprenorphine prescribing. Then Stephanie doing one on ADHD and SUD, and then Todd finishing out with trauma, adverse childhood experiences in SUD. It should be a really good series. And I'm going to send everyone an email. Actually, with email I sent out this afternoon. There's going to be a link to register for this series. So hope everyone is interested in registering and keep going with this. With that, I'm gonna stop sharing my screen here, and we'll do introductions for the Echo team. Ed, you want to go first?
Yeah, you bet. Ed Kaiser here. I'm a family trained nurse practitioner in Omaha, Nebraska. A little bit of background in like ER urgent care, but have been in substance use disorder treatment for about the last 5 years. So primarily treating patients with opiate use disorder with Suboxone. So really, really happy to be a part of the team and glad you guys are here today.
Gail, how about you?
Hi, I'm Gail Teller. I'm a nurse practitioner down in Falls City, Nebraska. I treat mental health as well as substance use disorders.
Janet?
Yeah, Janet Bernard, retired family practice doctor from North Platte, started treating people with buprenorphine in 2008.
Good morning, Todd Stull. I'm a psychiatrist that's worked in the addiction field in addition to psychiatry for a number of years. Thanks for joining, everybody.
Stephanie, are you on?
Yep, I'm on. I'm gonna have to log back out and log back in. But you guys, I'm Stephanie Bennington, psychiatrist in Omaha. I'm gonna turn on my video here shortly. I'm gonna have to log back out. But I treat addiction and also psychiatry. But just want to introduce myself.
Thanks. And John, I'll let you introduce yourself and take it away.
All right. Well, good morning. I'm John, and I'm a pain physician in a number of different places in the state, and also treat a fair amount of addiction, substance use disorders, as well as essentially an outreach of that. And I'm going to be talking about microdosing, initiation of buprenorphine today, and kind of try to talk over the advantages of that. And let me start sharing my screen here and see if I can do it right the first time. How's that look? Look, you got that? Hopefully.
Looks good.
All right.
Yeah.
All right. So interesting how we have been evolving with respect to buprenorphine and how we've been changing our approach to buprenorphine and how we get better at it and we do a better job with this. And microdosing, I first became aware of this actually through Ken Zuha a few years ago, and started talking about some challenging patients and inductions. And I would really encourage all of you to kind of think about how it would work for you clinically, because it's a very easy way to work with patients and use some of our other options, our techniques, and kind of good patient care to start this in a lot of folks. See if I can get this to advance. There we go. Sorry. So it's very interesting to me how easy it is to inadvertently stigmatize patients. And we've been thinking about this a long time because this data 2000 waiver, I think we've kind of stigmatized ourselves in the treatment. We used to need to go through this 8-hour course specifically for the use of buprenorphine in an office-based setting. We needed to, start out with 30 patients a year, and then after a year, if we didn't mess it up too bad, we got to go to 100. And we had to kind of in advance describe how we were going to put together a team to do all this. And that's, to me, stigmatization of the treatment, right? I always thought it was amazing that I needed less documentation to write for a boatload of Duragesic and Percocet than I did to unwrite for that. And so we want to think about the rationale for using buprenorphine and the fact that what we're trying to do is make our patients therapeutically better. And buprenorphine is really a molecule that helps us with patients. And the next part I want to say is that a lot of people, when they decide to come into the use of buprenorphine, they feel like they need to consciously make a decision that, okay, now I'm going to be treating opioid use disorder with medications, and I'm going to do it in my office setting. And we all have learned over time that that's a much slippery slope. It's a kind of a grade of how we address with these people. So remind ourselves that most of the patients come to the use of opioids initially because some clinician thought it was a good idea to prescribe opioids for a symptom complex. And the other part about that's interesting is that, as we've talked earlier in this series, is that something like 5% of patients are prescribed 70% of the MME in the country. And the patients who are prescribed the medications are typically the ones who are at highest risk of an adverse long-term outcome. That is, they have comorbid mental health diseases, they have a background, genetics, and environment that might put them as susceptible to opioid use disorder. And so we really have a lot of patients who are out there, and I think there's in my day-to-day, I see that there's a lot of patients who have been prescribed, and a lot of clinicians who are prescribing in ways, or they inherit patients and they think, hey, this isn't in the best interest of my patient. Now what? And that's a lot of consternation. And this method eliminates so much of that. And remind ourselves also that with the changes in the CDC guidelines last year, when patients come in and they're prescribed in a way that's outside of best practice, we are not to de-prescribe these patients against their will, because there's a real risk of morbidity and mortality associated with that. So what we want to do is find a better way to manage these people using our motivational interviewing skills and working with the patient to their therapeutic advantage rather than in a punitive fashion. And microdosing really fits that bill. Again, we all know these data. We don't have to go up with this, but just remind ourselves that despite the fact that we are doing a really good job improving our prescribing habits, the opioid epidemic is traveling on and getting worse year over year. That right now means fentanyl in the so-called third wave. Fentanyl derivatives, whether or not people intend to be using fentanyl, they're being exposed to fentanyl, basically thinking that they're getting prescribed medications that have been manufactured illicitly with cheap fentanyl. And microdosing is a way that we can address that as well. So one of the great times that you might want to think about it, or the most common places that we want to put microdosing in. And for me, it's really very commonly that chronic pain patient that may or may not have a fully definable DSM-5 criteria opioid use disorder. In a lot of ways, that becomes irrelevant with this, because what we're doing with microdosing buprenorphine initiation is we're improving their symptoms of pain. And there's a great deal of accelerating data shows that buprenorphine, despite being a partial agonist, is much more successful at the long-term management of chronic pain than even high-dose legacy opioids. So the other person is the patient who just can't bring themselves to initiate treatment for opioid use disorder because of fear of withdrawal. You know these patients where we have a conversation about when would it be a good time. We're using our motivational interviewing skills. We're not forcing prescribing on them. We're not doing this in a punitive way, but they continually sort of stall with that discussion just out of fear of the short-term anxiety, the short-term discomfort that prescribing. Another way, and I think this is particularly germane to Nebraska, is the home induction. And it's not always the patient who can or won't follow up with instructions. It's that patient who may have obstacles to getting back at defined intervals, whether it's getting a ride, having family members there, other kinds of changes. Maybe you're not in the clinic situation on a daily basis, so you have to find a way to kind of stretch out the induction. Another place is the pregnant patient. We don't want to keep a pregnant patient from the benefits of buprenorphine therapy and treatment for OUD, and yet initiating withdrawal is problematic with respect to the pregnancy. So this is a way that we can switch patients over more comfortably and more reliably, and do so in a fashion that prevents the withdrawal from developing. Another one is when we're really not intending to. I've used this in the past when we have a patient who comes in and they give us an MME number where they say, all right, I'm on this much medication, and we give them a schedule for weaning away and what have you. And then they come in and it's clear that we measure the cow scale and they're not ready. Instead of saying, all right, come back in a week, which they may or may not do, we can just attenuate our induction, start with a microdosing, and allow these people to get started in a treatment and see that it's going to go well. And then another one that's important is the fentanyl patient. As we all know, fentanyl is we don't know what people are taking. We don't know what they're ingesting. They've got this opioid with a specific affinity for the receptor that's challenging. And so this is a way that we can break into that process and get them comfortable. And then the last one, to be clear, is if you're not comfortable yet with buprenorphine, this is a very easy way to become more quickly comfortable, and it really allows you to develop confidence as you work through buprenorphine treatment for your patients. Got to know a little bit about the way that buprenorphine works. This is part of our old data waiver training, but buprenorphine is a partial agonist. That is much less meaningful with respect to partial efficacy. I say this 1,000 times a day. Even though we want to say that methadone and morphine and oxycodone is a full agonist, that means it will continue to block the mu receptor at dose-dependent, and respiratory arrest and so forth occur in a dose-dependent fashion. Buprenorphine is a partial agonist, so it will have an opioid-like effect up to a ceiling effect. And at that point, no matter what you do with dosing, essentially, you're not going to have the escalation of the adverse effects, and particularly respiratory suppression, that we're worried about. And that's different than naloxone. And naloxone is an antagonist at all doses. And I also think we need to kind of continue to reiterate for all of our audiences that the combined product, the buprenorphine / naloxone product, that is Suboxone, really, you don't need to think about the naloxone part of that. It's really just there as a REMS. It in effect, if somebody's attenuating the medication, that is, they're melting it on a spoon and injecting it, there's an advantage with the naloxone and preventing problems with that. But as it just sits there in the prescription on the tab or in the film, naloxone doesn't much matter. So this whole conversation about whether you need Subutex or Suboxone is really less important than most individuals initially give it to be. So we're talking about the different affinity, the relative affinity of these different opioids with the receptor, and that's kind of important because the affinity of these agents is different depending on which agent it is, and that makes a bit of a difference. So what's important to know about buprenorphine is that it will get onto the receptor and it has an affinity, but once it gets on, it also has a very long half-life. Its half-life is something like 34 hours compared to these other agents that may have a higher affinity for the receptor. So what that means is that you need to kind of work gradually with buprenorphine. The whole concept of microdosing is that you start buprenorphine in a very slow fashion and you just gradually fill up the receptors with buprenorphine that are otherwise either unoccupied or occupied with legacy opioids. So as the other opioids go through their process of uncoupling from the receptor, buprenorphine is there to very gradually sneak into the receptor and take hold and begin to do its work. And so in this fashion, when we're initiating buprenorphine, what we're able to do is begin this process without ever identifying of time when they're actually in withdrawal. So you start the buprenorphine while they're continuing with their legacy opioids, and you just sneak it up, and you go at a pace in which you fill up so many receptors. And then once you get the receptors filled up to an adequate degree, that's when you're going to be able to just discontinue their other opioids and they don't have any period of withdrawal. And I would also make the point, it's been our observation, and this is the thing that we had to learn in our instance with respect to analgesic efficacy. Individuals who get buprenorphine are more comfortable. They're getting more analgesic efficacy even as we take them off of, say, OxyContin or transdermal fentanyl or MS-Contin in combination with hydrocodone. As the buprenorphine is filling into their receptors, the symptoms that they're purportedly trying to treat, that is pain, are getting better, not getting worse. And until you see that with these individuals, it's a challenging thing to understand, and yet the data is out there. So what we're doing with buprenorphine is very repetitive, low doses with sufficient dosing intervals that don't precipitate withdrawal. So we start out very low, very slow, and we're giving the buprenorphine time to work into the receptors and to slowly accumulate, filling up the opioid receptors. And then eventually, just by being there first and having a longer half-life, then they're able to outcompete the other agents, as you will. And then once they replace that, then the individual doesn't feel like they're losing the effect of opioids. They're just translating it from an unsafe one into a safe one. Now, when we're going to get into the protocol, I'm glad we record this, and I'm going to say that you aren't going to just have a single microdosing protocol. This is not here to say, okay, here's a recipe, you know, half a cup of sugar, 2 cups of flour, and baking soda. This is to figure out kind of how it works and then to make it work for you. And there's a lot of ways to do it, and it's not one size fits all. But if you start to work this into your practice and understand how it goes, then what you're going to find out is that you can do this successfully, and you can make small adjustments that really kind of work towards helping the patient have the most comfortable experience, the one that works best for, you know, how they can come see you and what have you, as well as the rate of change that you need to accomplish in order to get them safer and more comfortable. But what we also have to understand a little bit are the different dosing formulations, especially in the US when you have some of the other agents that are out there, the Butrans patch, the transdermal patch, and the Belbuca, which is lower dosing than the generic buprenorphine and how we accomplish this. And really, it's important to consider those because there are some cost issues involved. And that is, you know, if you haven't done this yet, you'll hear from your patients all the potential avenues of opportunity to fall away from the switch, and cost is of course one that's meaningful to these individuals. So we have to work with that a little bit. The buprenorphine generic that we use most of the time comes as a film or as a tablet. And as you know, it's 2 milligrams or 8 milligrams. There's a 4 milligram and a 12 and a few others, but generally what's available to these individuals is a 2 milligram or an 8 milligram. And what I try to explain to patients, I spend a little time doing this, I talk about micrograms. Remember, we'll say to an individual, we're going to start you on 2,000 micrograms, or we're going to start you on 500 micrograms. And that way they can kind of understand how we're switching over and work with this. But fundamentally, I think this is one of the ones that we'll frequently use with an individual, and we'll just start them on a 0.5 milligram sublingual once a day for a few days. This one, we'll start them on that for the first couple days, and then we'll go up to 1 milligram or 1,000 micrograms twice a day. That would be half a strip twice a day. So they're using a strip. And then we go up to 2 milligrams for a while, and then quicker. What I want to say, and I think we should probably talk about this as a team, is it's been my experience that once we get individuals to about 4 milligrams a day, 4,000 micrograms, that's oftentimes 2 milligrams sublingual twice a day. At that point, I think that you can get some confusion on the part of the patient if they're still taking their legacy opioids. And so what you're going to hear from a patient if they're taking commonly, MS Contents, 30 milligrams twice a day, or they're taking maybe 60 milligrams a day of oxycodone, and you've had them continue with their opioids, then once you're on these medications, this case is with methadone, once you're on those doses, if you get to 4 milligrams, now you're getting to a dose that you're going to have to start to decide if they need to wean off their legacy opioids, or you need to slow down, because that's when you get a little bit of challenge and people can get symptoms that they interpret as not tolerating intolerance to the buprenorphine, rather than it's just a side effect of the agents competing with each other. But this one is particularly helpful because methadone is one of our biggest challenges, especially because of the fact that it's got a very long half-life for the metabolites that are sitting in there and that can lead to withdrawal, but its analgesic efficacy, as we might know, is much shorter than that. So a lot of times people are on very high doses, and the metabolism of that is very hard to figure out. So what you're seeing here is a very high dose of buprenorphine initiation and switching out of methadone only after a full week of utilization. Here's one that we've used at times as well, and I think this one is more pertinent to the population that many of us will see, and that is, you have a patient who's on high dose opioids, and you kind of judge it for one reason or another to not be at their advantage, and so you want to switch over. And taking time to take about a week's worth of time, 5 to 7 days and you can extend this if you want as well. But what you're doing is you're exposing them to 0.5 milligram of buprenorphine. So if you've got the 2 milligram film, that's the 2,000 microgram film, they're cutting that in quarters, which is quite possible. And they're just using that 0.5 milligram, 500 micrograms for the first few days. And then you go to 0.5 milligram twice a day for another day, 0.5 milligram 3 times a day, and then you go to 1 milligram. And what you'll see here is you're giving time for that half-life of the buprenorphine to build up. And then once you get to 4 milligrams, that's the time when you need to start to kind of encourage them. Now is okay. You've filled up enough receptors with buprenorphine, and you can pull away from your legacy opioids, and you can do so successfully. If you think about it, when we talk about, and sorry about the pharmacology, but half-life of 34 hours of a medication approximately, if you remember our training, it takes 5 half-lives to reach a steady state. So conveniently, 5 times 35 gets to be pretty close to a week's worth of time, number of hours. So when we're starting somebody on buprenorphine, it's about a week before the initial buprenorphine has reached a steady state. So it's building even if you're moving very slowly. So that that allows us in this fashion. This is, I think, a formula that's pretty easy to just adopt, and you can switch into these into buprenorphine therapy and then move from there. Another thing I want to say about buprenorphine, and I think it's left off in a lot of the formal training about microdosing, and I think that we're gonna have a better definition of this in the future, and is the idea that how a patient responds to buprenorphine is very different based on their physiology. We have a lot of talks within our practice, and many of you will be familiar with the idea that, all right, we've got a patient who's been on opioid prescribing for a long period of time. Do they have a use disorder or not? We're not sure. How are they reacting to the opioids? We know that no matter what we prescribe for them with respect to hydrocodone and oxycodone and fentanyl and adding in something else, they come back saying, that's not working. I'm still having pain. They're anxious. They're not doing well. They want those doses, or maybe they're using more of the pills than you prescribed and you're concerned about that. And what you don't understand is how much of this is use disorder physiology and how much of this is chronic pain physiology. And what we have found is the patients kind of tell us. And what I mean by that is when we see a patient and maybe we've got a little old lady with stenosis and COPD and obstructive sleep apnea, and she's just using 60 a day of hydrocodone. And you've also got her on some other agents that concern you. Somebody's had her on, a zolpidem, or she's been on benzodiazepines for a long period of time, or what have you. You just know that the risk profile is higher. Maybe they're on oxygen, what have you. If you start that person on an initiation of microdosing of buprenorphine, and you start them on 0.5 milligram once a day, and you get them to 0.5 milligram twice a day, maybe 0.5 milligram. So you're in the 1 to 2 milligrams of buprenorphine a day, they'll just stop their hydrocodone and come back to you and say, hey, I feel better. I feel good. I'm okay there. And you don't have to go into the full-on dosing of the buprenorphine. And that is, they'll say, it's doing a better job. I feel less medicated, if you will. And all of those things start to make a real difference to them. And now they can they don't have to go into those high doses, and yet maybe that same patient who you think is not developing a use disorder and they're doing well, you see them at their 1 month follow-up or a couple weeks later, and they say, I just feel like I need a little bit more. If I had a little bit more of that buprenorphine, I'm going to feel a little bit better. So all of a sudden you go from maybe 1 milligram or 2 once or twice a day, you go to 2 milligrams twice a day. I think 4 milligrams is kind of the spot where it's a floor for individuals who have full-on use disorder, but it's a bit of a ceiling for people who maybe don't have use disorder, but just need to improve their safety and their long-term sustainability with analgesic efficacy. And I like to think of it that way if it's not fully clinically accurate, because what I feel like that allows us to do is really work towards further destigmatization, right? We're treating the symptoms. The patient is going to tell us what they need. And with this medication, we can follow along with them, just give them rational expectations for the different choices they want to make. But we allow them to say, hey, I'm more comfortable at these lower doses, or I feel better on these higher doses. And the other part of that that's important is that unlike other opioids where an individual says, sure, I do great for, 3 times a day with hydrocodone for a while, but now I need it 4 times a day, and now I need oxycodone, that kind of ladder that we've seen these patients always go up. Once they reach the dose of buprenorphine that makes them feel better, we'll see them back 2 years later, and that's the same dose that still makes them feel better. So it's a stable dose, and we can do well with that. So I think it's important to understand that part of it. So the variety of the protocols is important to understand, but how we do it is really going to be something that you're going to want to attenuate. You just need to become familiar with the other agents, and you'll get a bit of experience as you go forward. And one of the things I want to talk about a little bit is the Butrans patch, because Butrans patch we can often access it in some of our patients that have a more challenging payer structure, that is, Medicaid and what have you. But there's some challenges with Butrans in that it's at a pretty low dose. Even the 20 microgram patch is 20 micrograms per hour, and that, when you double that up, that only gets you to 480 micrograms in a day, or 0.5 milligrams in a day. So it's been described a lot, and I see we'll see people who come to us after being hospitalized. The clinicians are ambivalent about how they're being prescribed. They say, go see those guys once you're discharged, and they put on a Butrans patch. It's a good way to maybe start the process of microdosing, but it's a little too micro in some ways. So you can add a second patch and move on, and there's other ways you can do that. The Belbuca branded versions, as you might know, have 75, 100, 150, 300, 600, 900, and those are kind of nice dosing regimens, but again, it becomes very expensive. So another protocol here for a more rapid induction, this is one where they're basically going from 1 milligram to 16 milligrams, which is a very strong dose for somebody with an opioid use disorder, maybe at higher risk, and you need to move more quickly. That one in some patient populations is going to be harder to tolerate, but it's also you're translating them over more quickly. Here's another one that talks about the microgram patch of the Butrans. So you've got a patient who's maybe on 30 to 80 morphine milligram equivalents, which would be very common for a patient who's been legacy prescribed for a pain disorder for a long period of time, that isn't doing well, isn't making progress. Maybe they've got a kind of pain disorder that's not opioid responsive, but a clinician has started them, or a series of clinicians have started them on these medications, and so there's concern that they need to switch over. And you can use Butrans in this fashion, but again, once you think about what we're using for Butrans at 240 micrograms per day, you're really not moving very fast into that range that you want to get to. But once you get to the 20 micrograms, again, you're at 0.5 milligrams a day roughly, and that's a higher dose of morphine. I feel like this dosing regimen is a little bit too slow, too challenging. If you've got someone at 80 milligrams a day of morphine and you're putting them on 0.5 milligrams a day of Butrans, you're going to have to switch into another agent. And so I would really tend to favor the generic buprenorphine that comes in the 2 milligram, even the film, and the film can be cut into fourths, so you can give 0.5 milligrams very successfully once a day, and then that's equivalent to this 20 microgram patch. One advantage is you don't have to trust the patient to keep doing it, right? Once it gets on there, you know that it's on there every day. There's just different ways, and really, if you're looking at what's going on here, is that you're using methadone to buprenorphine using a Butrans patch. I would say is a very I don't love this one, to be honest. I think methadone is one of the ones you've got to really work to get a methadone patient into other medications, including buprenorphine. And so what the Butrans patch adds to this is something that you can put on their body, and they have it irrespective of whether they use other medications. But you're really going to have to get into the higher dosing of the buprenorphine. Notice this is up to 32 milligrams a day of buprenorphine, which is really on the very high end of what we're using, but it is a way to get people from relatively high doses of methadone into buprenorphine therapy. All right, so that's my presentation on this subject. But obviously kind of thinking about cases is important. And I'm available with some cases, but I would like to keep some faith with the Echo Project plan, which is always, we're here to be a resource. So if somebody has a case they want to present and talk about, let's go about that. And if nobody does, I'm more than willing to provide that. Anyone have a case they want to discuss?
I have a case.
Awesome. Good morning.
Morning. So I have a patient who initially it was thought that she had progression or reoccurrence of her cancer. So, and she was having terrible pain kind of in the location where the PET scan had lit up. Ultimately, there's no evidence that she actually progressed. We're trying to figure out what's happening. But so she got put on opiates for cancer-related pain. And so she was up to 40 BID of OxyContin and I want to say like 4 of hydromorphone every 4 hours. And so once we kind of did the workup and we couldn't find evidence of the cancer, we weren't treating this as recurrence. I was like, I can't keep you on this. And so I did I weaned her as much as I could on the opiates until because she never got benefit going up on the OxyContin. So we weaned her back. She made it down to like 20 BID before she was like, okay, now I feel a little different. And then we did a buprenorphine microinduction using Belbuca. And she got to 750 BID, was able to come off her OxyContin, was still using like 2, maybe 3 of the hydromorphone a day, but down to 2 milligrams. And she did really well. For a while, she was just like, this is wonderful. I feel better than I have in a long time. This is great. And then some of her tendencies kind of started coming back where she was like, I needed more of the hydromorphone, some of the kind of stereotypical, like, please don't fire me. And I'm like, I'm not going to fire you. Like, I've stuck with you this long. Like, we're in this together. And so I eventually, with cost and everything and knowing we'll likely need to go up, I tried switching her over to the sublingual tablets. And so I gave her 2 milligram tablets. And I think she did a 2 milligram tablet just once. And she was like, my pain was significantly worse. Like, that was terrible. That was awful, horrible. And I'm like, I couldn't find any rationale as to why that was, other than, is it really just, I put her into, like, I kicked off all of her hydromorphone and she felt miserable for that reason. Okay.
I'm gonna give people here a little bit of a background, Amanda, about, so for those of you who don't know, that's a graduate level question right there for sure. That's a challenging case, but Amanda's a fantastic palliative care physician. She works with cancer pain patients and works with pain patients, and what she kind of skips through quickly, because that some of us on this might not understand, but so cancer pain is different, right? We're always treating cancer pain differently, not just because people have cancer, but it's particularly nociceptive. So there's oftentimes some ongoing tissue destruction due to the neoplasm. But once you find out that there is not ongoing destruction, now all of a sudden she's having to sort of pivot completely into more of a chronic pain idea, almost I would imagine almost surprised, like, okay, now we have to go in a different direction because this is an individual who's got more chronic pain, and now we have to keep this person comfortable, but there's a lot going on with that. And so that's a fantastically interesting case, and hard. Does the first question I would want to know, if you could kind of go through it a little bit more, is what the time course was while you're on the 1.5 milligrams a day of buprenorphine via the Belbuca to when you finally went a little bit higher. So you went from about 1,500 micrograms up to, and discontinued the hydromorphone with the higher doses. How long had that interval been, do you think?
So she had been fairly well controlled, and she never wanted to stop the hydromorphone.
Yeah.
It was kind of her backup. It was always there, but she had gone from like always asking for early refills to, taking maybe 2 in a day and pretty consistently doing that much for almost 2 months, where it was like a completely different person. Like her pain was always controlled. She was using minimal. And then it was like suddenly she was asking for those, refills right away and everything again.
Yeah. So a little bit of kind of dependence thinking, right? Yeah, that's so common.
And
We see that.
Sounds like a lot of anxiety too, and I think that it is really, you just use the plain buprenorphine, right?
I did. And she does have a very long-standing history of anxiety and depression.
And is she on anything for anxiety and depression?
Yes. So she was on max doses of Cymbalta and Geodon. Had been on those for years. I very much wanted to readdress that, look into that. She got very anxious, very worked up when I even suggested, let's try to think about anything different. Yeah. Had terrible anxiety around scans and her workup. So in this course, she also got prescribed some Ativan for the anxiety with the workup, and then also for nausea that they thought might be related to the cancer. So on top of this, she also has a benzo on board now too.
Yeah. Well, she had a fairly significant opioid, not too much, I don't mean that, but a fairly significant dose of opioids on board prior to this. So we know that her receptors are fired up, and I think it's just probably going to take more. I suspect she felt terrible, as you so rightly said. I think her receptors were empty. She was in withdrawal, and there wasn't enough buprenorphine to sit in it. Once they feel that way with buprenorphine, though, it's tough to get them to kind of trust you and try it again. But I think I would encourage, try to explain that mechanism that I think John, do you agree with that?
Yeah, that's a good point. I think what you get to is you're at that point where you're going to have to either push forward or retreat for a bit and push forward on a different day, if that makes sense. You can do either one, and I know you know that, Amanda, but yeah. What you wanted, I think the trick here is not to impugn unnecessarily the buprenorphine, because you've made a lot of harm reduction. You've covered a lot of ground. You've made a lot of progress, and in my experience, what happens at this point is they come in and say, okay, now that medicine doesn't work for me. It's terrible. I'm sick. I'm nauseated. I'm tired. And you have to really ask a lot of questions to figure out if it was too much or too little, whether the buprenorphine was, if the hydromorphone was too much in there and it needed to come down. In that case, you have to push forward with the buprenorphine, or if you want to just sort of slow down your progress and say, let's try this again in a month. And either way, it's going to work, but it takes a lot of kind of talking with the patient to say it's all okay, and we'll be able to come to that later. And if they feel your confidence, they'll stick with it. If you kind of wig out, and this isn't, if you wig out, then they're going to say, well, I'm allergic to buprenorphine, but I do great with hydromorphone, and we've all had that patient too.
Yeah, I agree with that. I think, you could say, I've seen this in other people. It is a tricky transition. What's happening is your receptors are empty and you feel terrible because of that. And we need to get those receptors busy. I mean, I would make it very simplistic. I would use drawings. I would use whatever. And I think either way is fine, either retreating and trying again, but it's important that I really think it's vitally important in her case that she understands it's not the buprenorphine making her sick. It's the empty receptors making her sick. She needs to understand that right out of the gate. You know, don't let that fallacy fester, because she will get that set in her mind that somehow buprenorphine is bad. And so I would really put out that fire right now, but then whether you proceed on or retreat is, you know, whatever you think with her.
What about other teammates? What do you guys think? That's a really good way to put that, Janet.
I was about to jump off, but I totally agree. Like when like if you come in with confidence of like, hey, this is what actually happened to you, right? You were on the pain pills, and then when you took more Suboxone, that got removed, and that caused you to feel bad. Like the precipitated withdrawals is like a really bad feeling, right? So like if you can explain to them like what happened, then we can talk about like, okay, here's our plan going forward to not make that happen. So more interval doses, continue that as we raise it, and then we'll drop it later. You know, dosing, you know, when was your last oxycodone or whatever compared to when you start the medication. So I think that, yeah, I mean, I think you're exactly on the right track. And I think more, if they've been taking opiates and benzos and whatever, like Suboxone in higher doses is going to be safe. Like we just have to kind of slowly increase. But I think you're on the right path. And I think she's going to get back to what she felt for the first 2 months was, I feel so much better, right? I don't feel worse. I feel better on the Suboxone. And I think you'll be able to wean the other pain meds. So yeah, I 100% agree.
And she is completely off the OxyContin. She is just doing the hydromorphone, and she's agreeable to go back to her Belbuca. And so we went back to her Belbuca, and she's been okay at that so far. And so we haven't tried to go for a higher dose of like the buprenorphine sublingual yet.
Well, you definitely brought us a challenging one today. Thank you for that, man. That's a tricky one. That delayed, and then the different dosing and the high dose, and then the multiple kind of diagnoses in there. That's a really great case. Anybody, do you want to go through another one? If we got just a few minutes of time, and I I can certainly just we could talk about something easier and kind of give you guys an idea. I was thinking of which patient to best bring forward, and I had a patient the other day that had a diagnosis of migraine headaches, and daily migraine headaches, no other formal diagnosis. I suspect there was some anxiety as well. And this is a gentleman who had been a manager of a car dealership and had, you know, limited resources. That doesn't have insurance for some reason with this, and his method of managing over the years has been one of two things. He had been on methadone 10 milligrams TID for a number of years, and that worked successfully for him. And then at times when people wouldn't prescribe that for them, he was getting oxycodone 10-325, and he was taking that 5 times a day, kind of requesting 6 times a day because it, you know, as it were, it isn't helping. He's getting breakthrough headaches. Somebody gave him butalbital, which was still on his list, and then he, of course, with these common migraines, was failing things like the CGRP drugs, and had never been able to consider Botox because he doesn't have insurance and what have you. But he's feeling well managed. He's not really using more of the medication, but he's got butalbital and high dose legacy opioids. He comes with migraine type headaches, and we want to switch him over. So how do we want to do that? And of course, the language that we use is important in the process in order to minimize, you know, loss of work and what have you with the switch over. Anybody have any thoughts about that? Meaning, ask me questions if you don't understand what the issues are.
Hi, this is Carol Herman from Gary. I have a patient with a similar history, except she's got some more acute pain And I introduced a little bit buprenorphine. She's interested, but I don't know how much it would help her acute pain as well. A year ago, she had rectal cancer. Her hydrocodone use increased with the symptoms from the radiation. A year later, I brought it up again. However, she had a sacral injury, which I think is probably related to radiation. She's trying to figure that out. She lives 100 miles away from me in Cheyenne. She's seeing a pain doctor in Cheyenne who won't do meds, which is fine. She's trying some injections without helping. She's going to move. She's going to see some orthos in Colorado to see why she has this bilateral hip and sacral pain that's so acute. But I'm afraid to switch her while she's got such this acute pain as well. But since she's also got this history of migraines, which she uses multiple meds like butalbital, hydrocodone, a benzo because she has some bipolar. She's a former nurse. So you know how you've seen these people, they escalate in your office over time.
Yeah.
But I finally was able to start that conversation with her and she's really open, but I'm afraid I won't address her acute pain because she can hardly walk right now.
Right. Well, I think it's worth addressing because there gets a lot of confusion, in my opinion, in chronic pain people's mind. I am no expert at all on the chronic pain thing, and I should shut up and let John talk, but I'll quickly say that I think they try to stretch out their pain medicines because they know they're going to run out. They say, oh my God, I have all this chronic pain. I stretch them out. Then the pain is terrible. I think they have rebound. I think they get that hyperalgesia. I think all of those things happen. And it gets interpreted as, oh my God, my pain is worse. But a thing that came to me as you were talking is that you also have the complication of lots of other physicians involved. And that gets really sticky as well. So I'm going to stop, John, you go.
Yeah, that's tricky. Plus, distances and what have you, Carol. Good morning. But the first thought that comes to my mind on that is that I understand it's as an acute pain and sacral discomfort, but I think we want to know a little more about that because you've got rectal cancer. So it's pretty easy to say, okay, there's a neurogenic component to this that's very significant. Has there been irradiation and what's going on, with all the sacral plexus there? There's a lot of chance of this being neurogenic, which would make you think one way, but then maybe something else is going on. You mentioned a sacral injury. So if there's a nociceptive pain, then she's going to be more responsive to your changes. But fundamentally, I bet what you're telling us and what your suspicion is that this is a kind of a real setup for neurogenic pain. And of course, there's some specific things we can do with that sacral pain. I'm thinking S2-DRG and what have you. But identifying if that is a if that is a neurogenic pain versus nociceptive might give you some information. And if it's neurogenic, then even if it's acute pain, remind ourselves that opioids really in the long run are generally negative. They have a paradoxical effect with respect to neurogenic pain. And so this would be a time that microdosing would be effective. Just from the standpoint of the underlying pathophysiology.
Okay, thank you.
Does that make sense?
Yeah, I wish I could send her up to consult with you, but from 100 miles away, that's probably not going to happen.
Yeah, that's as close as it gets around there, right?
Yeah.
Yeah, I understand. We could talk more about that if you, just how we could talk through it if you wanted.
Well, and your microdosing was really helpful. I have a couple of those older women with, what they're like, all of the oxygen and everything. And I'm like, oh, I could and I've had them in my mind, but I just didn't know how to microdose. So thank you very much.
Yeah. Thanks for being here. Todd, did you have some thoughts? I saw you turn on your camera.
Not in addition to what's been said around this question. I'd be happy to comment on another question that was in the chat, but I don't want to disrupt the flow of what's going on here.
Go ahead.
Todd, were you referring to the question about microdosing naltrexone for anxiety, depression, and autism? Yeah, you want to go ahead and take that one?
Sure. So This is a really complex kind of area. I'm going to try to tell you what I know and make some sense of it. So for years, and I've worked with individuals that have developmental disabilities, that there's been use of naltrexone at various doses for self-injurious behaviors. So let me preface that by saying this is kind of not a new area, but how about for autistic spectrum, anxiety, and depression? So let's do a little bit of background, if you will. There are basically 3 genes that code for the opioid receptors. And I'm only saying some of these things because it's kind of important to look at mechanism of action. So these 3 genes that have letters that go with them, like the RK1 and so on, you don't need to remember that, but these genes code for receptors. The receptors then, if you will, are in the membrane of different cells. And so this membrane has what are called G proteins. G proteins signal the release of substances like neurotransmitters, right? So there's these receptors that stimulate or modulate the release of neurotransmitters. Well, you've all heard of the mu receptors. There's actually 3 types of mu receptors. There are different types of delta and kappa receptors. Probably the ones you haven't heard much of are nociceptin receptors, so NOR, and then the zeta receptor, which we know less about. So these are types of opioid receptors, all of which, when they're stimulated or blocked, have different kinds of functioning. So what the thought is with naltrexone, which really at the doses we typically use, it's a big time blocker, especially at the mu receptor, less so at the delta receptor and less so at the kappa receptor, but it has effects on those. But for example, it's 100 times more potent as a blocker than some of the agonists are for going to a receptor. So naltrexone is really potent at the typical doses. When you use a smaller dose of naltrexone, the thought is that the blockade doesn't work the same way. It modulates the receptor almost to trick it to increase the level of endorphins, especially at the mu receptor. So if you use 1 or 2 milligrams of naltrexone, you get an increase in endorphins. Well, endorphins are things that create hedonic or pleasure, right? That this emotional tone that feels good. And so when you use a low dose, and for example, think of a runner's high having an effect on mood. Think of a runner's activity having an effect on anxiety. So the thought is, at least from my understanding of the science in this area, that a low dose of naltrexone can increase endorphins by changing the blockade of those receptors. And remember, I said I'm getting kind of into science, but now the proportions of the way they work, those receptors, is different. And so as a result of them being different, the G proteins that I talked about release different neurotransmitters that have an effect on mood and anxiety. I know that's kind of complicated, but so if you just think of a bottom line here, ordinarily, when you stimulate an opioid receptor, it has effects on dopamine, right? And we know that from the mechanism. Let me digress for just 1 second here, and I know we're getting detailed and running out of time. We want to make the world reductionistic and say the world's about dopamine and addiction, and it's not, okay? Dopamine has an effect. However, there's a whole range of different neurotransmitters and different parts of the brain that have receptors for different neurotransmitters that are affected through kind of this myriad of or this soup, if you will, of effectiveness. So dose, in this case of naltrexone, increases endorphins, or the thought is that would reduce anxiety, improve mood. And then there's some thought that modulate or regulation of the dose of naltrexone can not only affect the endogenous system that we're talking about, right? The endorphins, the enkephalins, the dynorphins, and so on, but that it can affect that sensitivity to pain and reward that we've been talking about. So pain and naltrexone is where this all started. I'm going to circle back to self-injurious behavior in this context, that if somebody is exhibiting self-injurious behavior, sometimes if you change that reward circuitry through blockade or modulation by using naltrexone, which we traditionally think of as a blocker, right? You can change behavior or the response, just like you can block the effects of opiates. Well, lower dose can maybe have a hedonic effect, if you will, meaning regulation of kind of one's emotion. And remember that at the low end of hedonia, right, are effects on the stimulation of the kappa receptor. You block the kappa receptor, the thought is you get anxious and sad, okay? You stimulate the delta receptor and it's anxiolytic, and you get a positive kind of effect on hedonic tone. Just like if you use a mu agonist, that increase or causes euphoria, right? So there's different effects on mood and emotions depending on the regulation of those receptors. So that's kind of, hopefully that helps a little bit to think about this. It's a really complex area. So if I've muddied the water, I didn't intend to do that. I was trying to merely point out that there is differences in terms of not only the genetic coding, which is where naltrexone is thought to have its real effects, but then the effects on the receptors, which are modulated through the neurotransmitters that are released by these G proteins. So I don't know if I've confused everyone or whatever, but it's not a simple kind of 1 + 1 is 2.
That's excellent. Thank you, Todd. Okay, I think we're
Real quick, I just want to say that on November or October 6th and November 17th, Todd is going to be talking about those issues more fully with the PTSD type of stuff and mood and anxiety.
beautiful.
Thanks, Judy.
There's one other question in here about how often we can go between visits with these patients. Of course, that's always based on clinical necessity and your judgment, but there is new DEA guidelines that say that we may go up to 3 months between seeing these patients if they're stable and we feel that that is safe, but functionally not more than that. And that's a question that's out there. And I always want to throw in that the state has its own thoughts on that, because it's kind of a dual regulation, and those specifics aren't out there. But my suspicion is that eventually they'll probably follow the DEA guidelines, and you can that advisory opinion came out this spring and is available online.
Well, thanks everyone. Hope to see you again. We'll be off in September, but we'll be back in October. And I'll be sending out some information about that later today, along with a link for the evaluation survey. So we hope to see you all back here. And John, if you could send me those slides.
You got it. They'll come out, you guys. I'll send them right now.
Thank you. And I think I'll send those out as well, because people might want to see those dosing schedules that you have in there. So thanks everyone. We'll see you in October.